Well, good morning. I'm happy to be here with everyone. We have a blue sky. It's going to be a beautiful day compared to our previous weeks. And so what we're going to talk about today is what to expect when you're aging. And I tried to choose some highlighted topics that I think will be beneficial. Each of these topics could actually be an hour talk easy alone, but I'm trying to give you some information that when you do go to your primary care physician, you feel you know what to ask, whether or not medication management is needed, or is it just a change in lifestyle. So what we're going to speak about today is hormones, heart disease, cancer, and osteoporosis. And so hormones, the good, the bad, the unknown. I think there's a lot of controversy about hormones that we've heard over the past several years. And if you do read the literature, it is quite confusing about what is the right thing to do. And again, this is something that we should look at patients as individuals because everyone's going to come in with different symptoms, different risk factors, and also family history. And so first we're going to look at Jan. This is a typical patient that I would see in the office. She's a healthy 50-year-old woman having hot flashes due to menopause. She has no family history of breast cancer, and the question is, should she take hormones or not? And so advantages of hormone replacement therapy. So we know that estrogen is the most effective treatment available for hot flashes. It prevents and relieves symptoms of vaginal atrophy. It prevents bone loss, and it does lower fracture risk. And it can stabilize or improve mood during menopausal transition. And so risk of hormone replacement therapy. Now, the majority of this data was pulled from the Women's Health Initiative. This was a large study that was done with the primary end looking at the risk of coronary artery events in individuals who are on hormone replacement therapy, estrogen, progesterone combined, or estrogen alone compared to placebo. And so when we look at estrogen only in regards of heart disease, it didn't show that there was necessarily a benefit or a risk associated with estrogen only with hormone replacement therapy. But we saw with estrogen and progesterone that there was an increased risk in heart disease. And looking at stroke, there was an increased risk estrogen and progesterone group. With breast cancer, estrogen only did not show necessarily benefit or harm, but we did see an increased risk of breast cancer in the estrogen and progesterone group. And dementia, there was a study looking at the cognitive decline or benefit associated with estrogen and estrogen progesterone in the same study. And it showed that with estrogen only that there was not necessarily a benefit or a harm in regards of cognition, but we did see an increased risk in dementia in the estrogen and progesterone group. So myths associated with hormone replacement therapy. Unfortunately, it doesn't prevent hair loss, it doesn't decrease wrinkles, it doesn't prevent memory loss, it doesn't prevent heart disease, and it does not increase longevity. And so we kind of come back to Jan. She's a healthy 50-year-old woman having hot flashes due to menopause. She has no family history of breast cancer. Is she a good candidate for hormone replacement therapy? And Jan would be. And when it comes to hormone replacement therapy, I think you always want to do the lowest dose for the shortest duration of time. And again, we may change this rule depending on the patient coming in, because again, we have to look at everyone as an individual. And so hormone replacement therapy. Women with an intact uterus, these individuals who have not had a hysterectomy, have to take progesterone in addition to estrogen in order to prevent endometrial cancer. Now, estrogen therapy, as I said earlier, should be given at the lowest effective dose for the shortest duration of time. So I don't have hot flashes. I have short, private vacations in the tropics. All right, so alternatives to hormone replacement therapy. And again, not everyone can take it. So what can we do in order to help with hot flashes during this transition? Well, there's medications out there that can be beneficial, and these increase serotonin. This includes Brisdel, Paxil, Zoloft, and Effexor. And I'll use these quite frequently with patients coming in. And for a lot of individuals, these medications work very well. And again, are not for the rest of their lives. It may just be 3-5 years, at even that length. I often use clonidine. Clonidine is an antihypertensive or a blood pressure medication. And I use this medication quite frequently when I have the patient coming in with hot flashes, not sleeping well at night. And a low dose of this medication taken in the evening can work extremely, extremely well. Black cohosh is an herbal supplement, again, that it can be quite beneficial. And you've probably seen this advertised on TV. This medication is called Aspina. This is in a class of medications called SERMs. And this medication has actually been approved to help in regards of women who are having vaginal dryness, atrophy, or having pain with intercourse. And that's where this medication is really targeted for that patient population. Now, there are risks with this medication. If a woman does have an intact uterus, this medication needs to be used with progesterone. And a newer medication that you'll hear about is a medication called Duabe. Now, this is a combination medication of estrogen and another medicine called Bezdoxifene. Now, this medication has now been indicated for the treatment of hot flashes and also osteoporosis. Now, Bezdoxifene is in a similar class as Aspina, but it has not shown to have the same risk of endometrial cancer. So let's move to heart disease in women. So the scope of the problem. 43 million women have heart disease in the United States. And I think that this is a pretty powerful statement here. Since 1984, more women than men have died of heart disease. And 1 in 3 women will die of heart disease. And so we're looking at the percentage breakdown of deaths attributable to cardiovascular disease. And as you can see, 49% are from true heart disease, 16.4% from stroke, 7.2% from hypertension, 3.4% from diseases of the arteries. And so we're going to Miss Roberta, who's a 60-year-old woman with a strong family history of heart disease. She smokes a half a pack of cigarettes daily, but is otherwise healthy and active. What can she do to avoid dying an early death from heart disease like her mother? So we have risk factors for heart disease in women: age, menopause status, family history, high blood pressure, high cholesterol, diabetes, smoking, and a sedentary lifestyle. So what can we do to reduce our risk? Blood pressure, the lower, the better. If someone does have high cholesterol, statin therapy is shown to lower the risk by 20%. And if someone is a type 2 diabetic, the longer that they've been a diabetic, it increases their risk for heart disease. And if those of you who are diabetics know that value, hemoglobin A1C. It's that lab test that we check every 3 to 4 months, and we want that number to be close to 7. When individuals are diabetics and the sugar's not well controlled, that blood sugar filters everywhere. It's in the nerves, it's in the arteries from head to toe. So these individuals are at high risk for heart disease. So the tighter the control of diabetes, the better they'll do. And smoking. Smoking cessation decreases the risk by 50%. 50% in 1 year. And get off the couch. Regular exercise decreases the risk. And my patients know that I'm a big proponent, big cheerleader about exercise. And as we had that group who was here this morning doing Zumba, choose something that you enjoy doing so you'll be consistent with it. If it's on the bike, if it's a dance class, if it's yoga, Zumba, choose something that you enjoy doing so you'll be consistent with it. So aspirin. It is no longer recommended for heart disease for prevention. This is prevention in women. But if an individual has had a previous stroke, a previous heart event, carotid artery disease, these individuals need to be on an aspirin. And before starting or stopping an aspirin, this needs to be talked with your primary care physician. Screening. We don't have a certain algorithm to say, at this age, we're going to do a stress test on this patient. So when someone comes in and asks, do I need an EKG? Well, this could be informative, but it's not sensitive or specific. So obviously, if a patient's coming in with atypical chest pain or chest pain, we're going to get an EKG. But if someone's coming in with new onset high blood pressure, that's an individual who I will get an EKG on. And treadmill. Treadmill stress tests show no benefit in asymptomatic women. But we also have to remember, we're not always coming in with what we think of as classic angina, elephant sitting on the chest, radiation down the arm. Sometimes it's as subtle as unexplained fatigue, persistent indigestion. It's that patient who's coming in and says, normally I can walk to the end of the driveway to get my mail and come back without any problems, but now I'm getting to the mailbox and I'm short of breath. It's harder for me to come back. These are things that we need to know as your physicians and also to allow us to screen appropriately for heart disease. And there is something called coronary calcium score. Now, this is a CT scan of the coronary arteries that is not, this study we use for a specific patient population. This can give us some information for some patients. And I will order this if I have a patient who's coming in with a strong family history of early heart disease who may be asymptomatic, but their cholesterol is borderline, and I'm trying to make a decision, is this the patient I should put on statin therapy? And so screening. We're back to Roberta. She's a 6-year-old woman with a strong family history of heart disease. She smokes a half a pack of cigarettes daily, but is otherwise healthy and active. What can she do to avoid dying an early death from heart disease like her mother? Most important thing is stop smoking. Stop smoking. And she needs to see her primary once a year for blood pressure, blood sugar, and cholesterol screening. Hormones and heart disease. So early trials initially showed that estrogen could have a favorable benefit on cholesterol profile. Initially, women on hormone replacement did have what we thought was a lower incidence of heart disease. But this study I talked about earlier, the Women's Health Initiative, was this mega trial that was stopped early due to an increased risk in stroke and in heart disease in the treatment groups who are on hormone replacement therapy. And so this graph is a little hard to see, but what I wanted to show you is that in the top graph here, we have, and this is estrogen only, estrogen and placebo. And estrogen is the red, the top line. And as you can see from the top graph here, from 50 to 59, it looks like that there was some benefit with estrogen alone. And then the middle graph here, the age group is 60 to 69, and they're kind of running almost hand in hand, as you can see. But now when we get to 70 and 79, we see that there's an actual increased risk in heart disease associated with the estrogen group alone. So this was placebo, and the other arm was individuals who were on estrogen plus progesterone. And as you can see from the get-go that there is an increased risk of heart disease in those individuals on hormone replacement therapy, combination hormone replacement therapy, compared to placebo. And this is a reason why the study was stopped early. So cancer in women. So this is the annual number of new diagnoses of cancer, but this is per 100,000 patients per year. So 100,000 patients per year. 125 in breast, lung is 51, colon 38.2, and ovarian 12.3. And so the mortality per 100,000 women per year, lung 38.5, breast 22.2, colon 13.5, and ovarian 7.9. And so we have Miss Susan here, who is 52 and is beginning menopause. She's worried about her risk of breast cancer since she had a cousin who was diagnosed at the age of 58. What can she do to lower her risk? And if her hot flashes worsen, is she a candidate for hormone replacement therapy? And so hormones and cancer risk. When we look at breast, estrogen has really shown no benefit or harm, but estrogen and progesterone group has had an increased risk of breast cancer. Lung, no change. Colon, estrogen alone did not show an increased risk or benefit with the prevention of colon cancer. And with the estrogen and progesterone group, it was mixed results, meaning that there was a lower incidence of colon cancer in these individuals, but if they did develop colon cancer, it was more of a lethal form of this cancer. And then ovarian, we think it's probably increased in both, but because the incidence of ovarian cancer is not as high as breast, it's hard to actually get a good study performed to be able to answer that question completely. So risk factors for breast cancer: age, family history, early menarche, the age before 12, obesity, sedentary lifestyle, alcohol consumption, and hormone replacement. So the impact of breast cancer, and I think a lot of us are familiar with this statement. 1 in every 8 women will be diagnosed with invasive breast cancer in their lifetime. Breast cancer is the second most common cause of cancer death in women, but breast cancer is the most common cause of death in women aged 40 to 59. So we go back to Susan, who's 52, beginning menopause, worried about her risk factors for breast cancer because her cousin was diagnosed at the age 58. What can she do to lower her risk? If her hot flashes worsen, can she take hormones? Avoid tobacco, limit alcohol, exercise, and have regular screening. And she would be a candidate for hormone replacement therapy if needed. So decreasing cancer risk. Avoid tobacco, limit alcohol, stay physically active, and get screened. So cancer screening, and this screening is for those individuals who don't have a family history of breast cancer or colon cancer. Mammography at regular intervals beginning at age 40. Colonoscopy at least every 10 years starting at the age 50. Cervical cancer screening with pap smear every 3 to 5 years beginning at the age 21. We are now doing HPV testing when we are performing these pap smears. And lung cancer screening at the age 60 for those with a long history of tobacco use. And screening guidelines for lung cancer have changed. We are recommending low-dose spiral CT chest scans for those individuals who are 55 to 75 who've had a 30-pack-year history of smoking, or those individuals who have quit 15 years prior. So now we're going to move to osteoporosis. So we have Doris here. She's 73 and has completed the menopause transition. She tries hard to maintain good health. Her mother died in her 70s from complications of a hip fracture, and Doris wants to improve her risk as much as possible. What can she do? Can she take hormones? So risk factors for osteoporosis: gender, age, race, family history, low body mass index, smoking, excessive alcohol, and again, a sedentary lifestyle. So if we're looking at the prevalence of osteoporosis, and this graph is showing the percentage of females aged 65 and above who have osteoporosis based on race and ethnicity. So for Caucasians, 21%, African Americans, 6%, Hispanic, 18%, and other, 11%. So mortality and morbidity from osteoporosis. About 30% of women that live beyond the age 80 will suffer a hip fracture. 10% of women who are aged 50 have osteoporosis of the hip. And that's 10% of women who are 50, osteoporosis of the hip. 4.5 million women in the U.S. do have osteoporosis. And the mortality rate from a hip fracture is similar to the mortality rate from breast cancer. So hormones and osteoporosis. We know that estrogen is very important to bone health. And when someone starts losing estrogen or estrogen starts to decline, we do see bone loss start to decline quite significantly. Estrogen replacement does prevent or retard the loss of bone after menopause. But there are other medications that we can use to help prevent further bone loss. Avista, another class of medications called bisphosphonates. These are medications like Actonel and Fosamax. So we're back here with Miss Doris, who's 73, has completed the menopause transition. She tries hard to maintain good health. Her mother died in her 70s from complications of a hip fracture, and she wants to know how can she improve her outcome? What can she do? Can she take hormones? Well, weight-bearing exercise, calcium, vitamin D, routine screening with DEXA scans, bone density scans, and these are typically performed every 2 to 3 years. And she's not a great candidate for hormone replacement therapy, but I think most physicians would agree that if she did have osteoporosis, she would be a candidate for possibly a bisphosphonate. So what should we worry about? What should we worry about as we age? And this is a graph to show you, based on age, the risk from death from heart disease as well as cancer. And as you see, as we age, what happens is the risk of cardiovascular disease increases dramatically. So 1 in 3 women die of heart disease, and 1 in 30 women die of breast cancer. These are both conditions that warrant attention, screening, and as we know, we've all had someone in our lives who's been afflicted with heart disease or breast cancer who did everything the right way. And these things do happen, but we try to control our risk factors, and we also try to change screening, be vigilant about it. And so I can only please one person per day, and today I choose myself. And I say this to my patients who come in. So as women, we're mothers, we're grandmothers, we're teachers and lawyers, we work, and we always seem to make sure that everybody else is taken care of. The children are looked after, the house is clean, work is done. And so a lot of women come in and they've taken themselves off the to-do list. And that's what I say. They've taken themselves off the to-do list. And you have to put yourselves back on. You have to carve out that time to go exercise. You have to carve out that time to go have the mammogram, the colonoscopy. And so I encourage everyone to make that become a priority so that you start this now so we can prevent some of these conditions down the road. So I'm happy to have had this time to speak with y'all. I hope you enjoy the rest of your day.